Hello, everyone. I'm looking at Lizanne Roberts, who is joining us tonight for this discussion on why Georgia's healthcare system is in such an unhealthy state. Lizanne has spent her career in public health. She's been in Savannah for 15 years and along with Mayor Otis Johnson, founded Healthy Savannah. She has served as the executive director of Coastal Georgia Indicators Coalition, otherwise known as CGIC, since the fall of 2017, and she's an active community leader. The work of CGIC includes coalition building, community and partnership development, evaluation, planning, and implementation of social determinants of health initiatives. She's also a founding board member of Healthy Savannah, a community-based health initiative held as a national model of leadership for social and environmental change grounded in equity. So on this rainy night when everybody's happy to be on Zoom, I, Nina Altschiller, president of the League of Women Voters of Coastal Georgia, am happy to introduce you to Lizanne Roberts.
Thank you, Nina. I'm so glad to be with you this evening and this distinguished group of panelists that we have before us. I think this is going to be a great informative time for all of us. We're going to invite you as each speaker is giving their talk to put your questions in the chat feature so that we can come back to those at the end of the program and go through some of the questions that you may want to have answered by this wonderful group of people. So we're going to start with David Radley. David is a senior scientist with the Commonwealth Fund's Tracking Health System Performance Program. Dr. Radley and his team develop national, state, and sub-state regional analysis on healthcare system performance and related insurance and care system market structure analyses. He leads all of the Commonwealth Fund's state scorecard and data work. He's also a study director at Westat, a research firm that supports the scorecard project. Dr. Radley joined the fund in July 2010 from ABT Associates, where he was an associate in domestic health policy with responsibility over several projects related to measuring long-term health quality and evaluation of various health information technology initiatives. His methodological, the expertise is in a small area analysis and in the design, implementation, and interpretation of observational studies that take advantage of large administrative and survey-based data sets. Dr. Radley received his PhD in health policy from Dartmouth Institute for Health Policy in clinical practice in 2008. He holds a BA from Syracuse University and an MPH from Yale University. Please welcome Dr. Radley.
Thanks, Lizanne. All right, I'm going to share my screen here and all right, so thanks very much. Today I'll be talking to you a little bit about how some of our recent work in state health system performance measurement, how that has identified opportunities for improvement, in this case in Georgia. Before I get started, I'd just like to acknowledge that all of the work that I'm going to be showing you today is done in collaboration with my colleagues at the Commonwealth Fund, particularly Jesse Baumgardner, Sarah Collins, Lori Zephyrin, and Eric Schneider. There's a host of other support staff. These are my key research partners. My contact information is here. If at any point you'd like to ask a question offline, feel free to email me. I don't really use Twitter very much, but my Twitter thing is here. You can try to get me there, but email is better. So the Commonwealth Fund has done a series of health system scorecards for about 15 years. It started when we, as an organization, we really wanted to sort of lay out a blueprint for how we thought the country could do better in terms of its healthcare. In order to sort of understand how to do better, I think the idea was we needed to know where we were today. And today, in this context, was in 2006. So we had this first national scorecard that compared the US really to a lot of international benchmarks to see how well we were doing on key measures of healthcare access, healthcare quality, healthcare efficiency, health outcomes. And more recently, we've added different ways of measuring health equity to that mix. Our state scorecard has become the anchor of our scorecard series. We've done that almost annually for the last several years. But we've also done several scorecards that take a look at either local healthcare systems, like healthcare markets around the country, as well as scorecards for from some specific populations of interest. Most recently, we released our first health equity scorecard in fall of 2021. And I'll be showing you findings from sort of a lot of our work, not just the equity scorecard, but from a lot of our scorecards over the last few years. We build our scorecards almost entirely from free publicly available data. Really, this is an exercise in gathering up and massing public data from other sources and pulling it together to try to weave it into a narrative about what's going on for each state in the country. So why do we do these scorecards? We do the scorecards because we know they motivate change. This is a tweet last week from Robert Reeves, the Democratic leader in North Carolina's House, and he found our scorecard and used this, in this tweet in his efforts to push Medicaid expansion in North Carolina. So we find little examples like this all the time. This is a recent one, but that's why we do the work. We really want to, give people the information that they need sort of to pursue the things that are important relative to improving healthcare in their state or in their city. So let's focus on Georgia. So what's going on in Georgia? In our most recent scorecard, our 2020 scorecard, we've got a new one coming out later this year in June 2022. But in our most recent one, Georgia ranked 46th out of 51 states. In terms of an overall ranking, I think that points to opportunities for Georgia to do a little bit better. But when we dig in, we can start to understand a little bit about where those opportunities actually exist. Georgia ranked 49th out of 51, almost last on measures of healthcare access and affordability. I'm going to talk to you a lot about those measures. But I think what also stood out to me was that Georgia really even lags behind other southeastern states, ranking 9 out of the 12 states that we sort of group together as being southeastern states. Again, here 11th out of 12 in measures of healthcare access and affordability. I think that really does point to opportunities to think about changing policy in Georgia in ways that could help Georgians. It's not necessarily about getting the ranks up, but it is about helping the people of Georgia have access to the healthcare that they need. So let's talk about access. 1 in 5 non-elderly adults, and these are adults aged 18 to 64, are uninsured in Georgia. That's well above the national average. It puts Georgia, it ranks Georgia 47th out of 51 relative to other states. As far as an overall uninsured rate, that's pretty high. There's no two ways to slice that. When we start to think about who's uninsured in Georgia, we get a little bit deeper picture here. It's probably not a surprise. Low-income people in the state, these are individuals with incomes less than 200% of the federal poverty level. They've got a very high uninsured rate. 35% of low-income individuals are uninsured. Even middle-income people, though, these are households with incomes between 200 and 400% of the federal poverty level, have a relatively high uninsured rate, certainly high relative to that middle-income group in other states. If we look at this data on the left side of this chart, stratified by race and ethnicity, we can see that communities of color in Georgia are more likely to be uninsured. Blacks have an uninsured rate at 21% in the state, and Hispanic individuals at 41%. Those patterns mirror what's going on nationally. but again, I think if we're trying to identify opportunities to do better, this data certainly points to it. So, insurance coverage matters, and it matters because it reduces barriers for people getting care when they actually need it. On the left side of the plot, it's no surprise that Black and Hispanic individuals are more likely to report having foregone needed care because of its cost. If Black and Hispanic individuals are more likely to be uninsured, it just makes sense then that they're probably less likely to have that sort of cost protection and have to skip care because it's too expensive. So these kinds of disparities and these cost-related barriers reflect differences in uninsured rates, but also in underinsurance. This is underinsurance is this idea that there's high cost sharing, high deductibles, high copays, that there's high cost sharing that can, even among people who are insured, can still prevent them from seeking needed care. You can't necessarily see it in the chart, but research also shows that Black and Hispanic people with employer coverage, they're more likely to have high out-of-pocket costs as well. Again, feeding into this idea that there's a group of individuals, even when they're insured, who can't always get the care that they need because it's just too expensive. In the plot on the right, we see that Hispanic individuals are far less likely than other groups to report having a regular source of care. Again, having this regular doctor, somebody that you think of as being your point of contact to the healthcare delivery system, is an hugely important aspect of actually being able to get care when you need it. If you have a primary care doctor, you're less likely to have to seek care through the emergency department as your first point of contact, for example. That which when you go to the ER, chances are you're not going to get care that's good from the point of view of having good continuity. It's going to be more expensive. And so, so having that user source of care is another key measure of healthcare access that really can help people get in the door when they're sick. Having coverage by itself isn't always enough. I alluded to it on the last slide, but we know that there's people who face huge medical bills. Huge medical bills, even that go even beyond the cost of buying their insurance. So here you're looking at a map of adults with high out-of-pocket medical spending relative to income. This is the dollars that people spend on medical care, the dollars that show up in their deductibles, the dollars that show up in their copays. These are actual direct payments to doctors, to hospitals, to pharmacies, whatever, for actually receiving care. This is not the cost of insurance, but still we see that medical costs take up, for the sort of highest group of states, 8 to 12% of people's annual household income in direct medical payments. That's high. Georgia's higher than the national average, 8.1% in Georgia overall compared to 7.3% nationally. But again, if we're looking within Georgia at who actually has the highest out-of-pocket medical spending, not surprisingly, it comes to low-income individuals. 17.4% of low-income Georgians face these high medical bills relative to their income. Again, by race, ethnicity, I've got the breakdown here. Different racial and ethnic groups have pretty similar percentage of them have high out-of-pocket medical expenses. So really, this is burdening low-income individuals disproportionately. Of course, we think about healthcare access as a way to get into the healthcare system so that people are healthy. So it's important to be thinking about healthcare outcomes. One of the key measures that we track in our scorecards is this measure of premature death. These are deaths before age 75 from healthcare treatable conditions. In other words, deaths where sort of early disease recognition and effective treatment really can make a difference. So it might include things like tonsillitis or deaths from diabetes. Again, deaths early in life from diabetes. Certain screenable cancers fall into this category. And what we can see in this chart is that preventable mortality rates are higher for Black individuals than for white individuals and Hispanic individuals in every state where we have the data to be able to measure this. And in some cases, those rates are even twice as high. Differences within states reflect unequal access to healthcare and unequal healthcare utilization. With and we know from other research that rates of premature death, they're linked to poverty, they're linked to insurance status, and really they're linked to access to primary care. Primary care is so important. Again, coming back to that notion of having that usual source of care, that usual provider that can link you to the healthcare system. Not having access to good, reliable primary care really puts you in a position where you're less likely to identify diseases early. You're less likely to have effective care management over the course of a chronic illness, and this is the result. We know that infant mortality is a problem. It's a problem nationally. If you compare the U.S. to other high-income countries, our infant mortality rate is higher than all of them, and in Georgia, it's particularly a problem. The infant mortality rate in Georgia is higher than it is nationally. Nationally, we know that babies born to Black mothers are more likely to die within the first year of life. That's also true in Georgia. Those disparities are about the same in Georgia as they are nationally. It's a big problem, and there we know how to solve infant mortality. At least we know things that are effective in terms of prenatal care, postpartum care for moms. Again, having coverage so that women who've given birth, can bring themselves and their babies to the doctor. These are all important things, and yet we still have a huge infant mortality problem in this country. Of course, it's not just about infant mortality. Another major concern is maternal mortality. Again, this is another area where we've got sort of a very well-established and acknowledged disparity by race. Research has shown that Black women are 2 to 4 times more likely to die following childbirth than white or Hispanic women. And we can see in this chart that Georgia has one of the highest, among the highest anyway, maternal mortality rates in the country. We don't have data for every single state. Fortunately, in some states, the counts are just low enough where we can't create an estimate. I mean, I think we can agree that that's a good thing. But in trying to understand these patterns, researchers have found that Black women, particularly, they're more likely to report being treated unfairly by their healthcare providers, not having their specific concerns heard, not feeling like the care that they're receiving is in line culturally with where they feel like they need their care to be, and they're more likely or less likely to report breastfeeding at certain intervals after giving birth. So, again, there are things that we know that can be done to help reduce maternal mortality. This is a problem that's getting a lot more attention nationally. I think it's going to continue to just, as we learn more about it, as the data feeds become better on maternal mortality, we're going to just continue to realize that, how big of a problem this is, and hopefully figure out ways to start to tackle it. Shifting gears a little bit here, we've heard a lot in the last few months, last few years, however you want to think about it, about the opioid epidemic, and for good reason. I mean, since early 2020, drug overdose deaths have absolutely skyrocketed. This is due to a number of factors, including a big influx of synthetic opioids into the U.S., including more risky drug utilization patterns that sort of were tied to social isolation during the earliest months of the pandemic. But the drug overdose crisis has just becoming more of a crisis everywhere we look. If you think back historically, Georgia wasn't a state that had one of the worst drug overdose problems. If you go back a few years, we think of Kentucky, Ohio, West Virginia as being the states where this was really the worst. But I think what's striking is that you can see in the bars on the right that the number of drug overdose deaths in Georgia grew faster between 2019 and 2020 than they did between 2010 and 2019. So this is over a 30% jump in Georgia in the last in the year between 2019 and 2020, and it actually is putting Georgia on the map as being one of the states that has one of the biggest problems with drug overdoses. And so I certainly think that it's something to be thinking about and paying attention to if you're trying to sort of set an agenda for sort of health improvement in the state. So, you know, I talked a lot at the outset about healthcare access. I know that Georgia is not an expansion state, and it's maybe something that's being considered there. Whether it is or not, the data doesn't lie. We know that states that have expanded have seen bigger gains than states that haven't expanded in terms of you know, their coverage gains, and in terms of if we look at another set of measures, look at people that get back to that measure of having foregone care because of cost. And so, you know, expanding Medicaid in Georgia would most likely it would have a huge impact. It would reduce the number of uninsured, particularly among those low-income cohorts that I showed you in the outset. And it would have a meaningful difference in the state. So I'm not going to get too much into the policy implications here. There's other panelists that will really dig in and be able to talk much more specifically about Georgia than I can. But I think there's a few principles though that sort of, you know, that are worth mentioning. You know, having a high-performing health system really requires ensuring that people have access to universal, affordable, and equitable health coverage. We can strengthen primary care systems and really focus on improving delivery of specific types of specialty services, specifically prenatal, postpartum, and mental health services, if we're thinking about some of the biggest problems with infant mortality, maternal mortality, and drug overdose deaths. We know that nationally, our healthcare system has got more administrative burdens than healthcare systems in other high-income countries, and that those administrative burdens disproportionately affect low-income and disadvantaged individuals. And so anything that we can do to reduce those types of administrative burdens would be a welcome change in health systems across the country. One of the big problems, particularly with measuring health system equity, is we don't have good data on the race and ethnicity of individuals who are receiving care. And so there are efforts underway in some states to improve the collection of racial and ethnic identifiers through administrative processes to make sure that we actually can track what's going on in terms of healthcare quality and health services delivery by race and ethnicity. And of course, there's always opportunities to sort of invest in social services. Healthcare only accounts for about 20% of health, and so much more of that other 80% comes from the environment. It comes from your access to healthy food, to, you know, all the other stuff that I think we all recognize as being important. And so there's always opportunities to do more to link social services to people's health. I'll stop there, and I guess we'll pause questions on this and then have questions at the end. I think it's how this is going to work.
Thank you, Dr. Radley. If you have questions for Dr. Radley, if you could drop those in the chat feature, and we'll come back to those at the end. We're going to go to Lauralbert. Laura has served as the executive director at Georgians for a Healthy Future since 2017, and prior to that appointment, served as the community outreach manager. She previously worked at CHOA, Children's Healthcare of Atlanta, HSTAT, a student-run health policy and advocacy organization, and the CDC's Division of HIV/AIDS Prevention. Laura served as a consumer liaison representative to the National Association of Insurance Commissioners from 2018 to 2020. She currently sits on the Georgia Department of Community Health's Medical Care Advisory Committee. Laura earned her MPH from Emory University, where she focused on health literacy and the social determinants of health. Previously, she attended the University of Georgia, where she studied biomechanics and earned her BS Ed. She is also a master certified health education specialist, and she lives in Atlanta with her husband, 2 dogs, and many bicycles. Welcome, Laura. We're glad you're here.
Thanks, Lizanne. It's nice to be in a virtual space with you this evening, and nice to see everyone else this evening as well. Thank you all so much for having me. As Lizanne said, I'm the executive director at Georgians for a Healthy Future. And I'm going to spend a little bit of time on kind of mental health and private insurance in Georgia and what's happening at the Georgia legislature currently on these issues. There's a lot to cover, so I'm going to cover some of it in detail, and I'm going to breeze over some other pieces, but we can always come back to it in the question and answer. And then my colleague Leah, who will speak after me, is going to touch on some of the other things that are happening at the legislature. We did a little bit of divide and conquer, which is also a good strategy when you're advocating at the Georgia Capitol. Is what it's a strategy that we employ quite a bit. Georgians for a Healthy Future is a consumer-focused health policy and advocacy organization. For us, that means that we work to improve health and health equity across the state of Georgia, and we are especially focused on marginalized groups in Georgia, so folks who have special barriers to care. David dove into a lot of those folks. They are often communities of color, people with disabilities, LGBTQ populations, so folks who have historically kind of had experienced worse health outcomes because they've been systemically discriminated against or locked out of our healthcare system in some way. This is our Georgians for a Healthy Future team. You can see we're an incredibly good-looking group. And this is from our little Christmas outside get together last December. We went to the Atlanta Botanical Gardens. At Georgians for a Healthy Future, we cover really kind of 4 priority areas as we think about our work. One of those is getting Georgia covered, which is really about making sure folks in Georgia have health insurance coverage. And as David mentioned, Georgia has an incredibly high uninsured rate. And we are working to reduce that through policy change. We also work on increasing access to care, which is for us a recognition that your insurance card doesn't mean you get the right care at the right time and in the right place. Enhancing value for consumers is about really lowering the costs in our healthcare system while we're improving equity and really bringing those things into balance. And then building a healthier Georgia is our recognition that most of our health, as David said, is determined by things that are not your health insurance and that doesn't happen in your doctor's office. So that's kind of where we come from. And our perspective on health policy and legislation is really from the perspective of consumers. So we try to engage communities. We talk with Georgians every day. We do story collection. We look at the data that groups like the Commonwealth Fund have put together, and we really try to bring that to our Georgia legislature so that folks who are working hard and need access to healthcare have a voice when decisions are being made about that will impact their care, their coverage, and their health ultimately. Diving into the 2022 legislative and policy issues that are on the table this year. You all may have seen many headlines declaring 2022 the year of mental health at the Georgia General Assembly. There has been a really strong focus on youth and adult mental health. There have been a number of mental health and substance use outcomes across the pandemic that have worsened over the last few years. David mentioned addiction and overdose. We've also seen suicide rates rise, especially in rural areas, as well as emergency room visits for mental health and substance use issues. So the need is there. And the Speaker, David Ralston, the leader of the House of Representatives here in Georgia, introduced a very large 80-page bill which is its official title is HB 1013. We don't call it that. We call it the Georgia Mental Health Parity Act. It is made up of a number of pieces, but I'm going to touch on kind of that big headline piece, which is the parity piece. The term mental health parity or behavioral health parity really just means that mental health and addiction are treated or are covered under insurance in the same way that other health conditions are. So if if your insurance plan covers diabetes care, then it should also cover mental health and addiction conditions and services. And so there is a federal law that requires insurance companies to treat these conditions at the same level, but it hasn't been well enforced for the last 14 years. In fact, in Georgia, it's just largely been disregarded. And so this state bill, what it would do is it would direct our state to actually implement parity across both private insurance companies as well as public insurance companies. So all of us with private and public coverage that's regulated by the state would be impacted by this. And what that means is it's really going to improve the quality of the coverage to make mental health and addiction services more affordable and easier to access for people. That's kind of the bottom line with parity, is to really bring that into line with other services. There are also some really incredibly important provisions in this bill that would help develop our behavioral health workforce. And that includes providing a student loan cancellation program so that folks who are training to work in mental health or substance use and are training to kind of fill these workforce gaps that we have, that their student loans will be forgiven when they enter the workforce and meet some certain requirements. There are also, you can see 4 other kind of sections of this bill, and I'm going to put in the chat a link to a mental health parity fact sheet. GHF developed a fact sheet that kind of covers each section of this bill and talks about kind of what it does and why that's important. And hopefully that will help kind of make each of these pieces more understandable. But the parity piece is really the headline and will really impact the most people across this bill. What I will say is that this bill got through the House of Representatives with a vote of 169. That's a bipartisan vote, 169 to 3. So there were 169 representatives in favor of this bill. There were 3 representatives who opposed it. So it is a highly bipartisan bill. There's a lot of agreement about the need and the urgency for this large package of legislation. It has hit some roadblocks in the Senate, largely because there's disinformation being spread about what the bill does. And so I would like to ask you all tonight to call your Senator Ben Watson, to show your support for the bill. He is on the subcommittee considering this bill, and they have heard a lot from people who oppose, again, an incredibly good bill. And those folks oppose it largely for reasons that are false and just not true about the bill. And so I hope that you all will kind of look over the fact sheet and give Senator Watson a call. He definitely needs to hear from you about why you support it, and to urge them to move forward on it. There are also a number of other things happening around mental health and substance use in the Georgia legislature. So what you'll see here is that there are also a number of investments in our state budget that would help to improve mental health and substance use. One of those is one of the investments is $127,000 that would create kind of a mental health parity coordinator position at our Department of Insurance. This position is incredibly important for implementing the bill that I just talked about, the Georgia Mental Health Parity Act. So without this coordinator person, a lot of that bill can't be enforced just because the Department of Insurance doesn't have the capacity to take on the extra responsibility. So this position, incredibly important in addition to that bill. The budget also includes $5,000 for cost of living raises for the Department of Behavioral Health and Developmental Disabilities for employees working in that department, and also across all of our state departments. But it's especially important in this department because about 1/3 of these positions are unfilled right now. So the department typically employs about 3,000 people. Almost 1,000 of those positions are unfilled. And these are positions that staff our state mental health hospitals that help to answer calls at the crisis call line. I mean, these are folks who interact with people with mental health and substance use needs on a daily basis. So raising that their pay and hopefully getting some of those positions filled is going to help improve access for folks, and at least kind of keep us at the current status quo, as opposed to kind of eroding access to mental health and substance use services. There are also in the budget, there's also some investments made in community-based supports for people with intellectual and developmental disabilities through what are called Medicaid waivers, and as well as a $1.4 million increase for the Georgia Housing Voucher Program. And what that does is it helps move people from mental health and hospitals into community-based living. And so that program is incredibly important. There are a number of other bills here you can see that also would impact mental health in one way or another. Most of these are very positive, with the exception of SB 435. For the sake of time, I'm not going to dig into each and every one of these, but I will mention the other one that Senator Watson is sponsoring is Senate Bill 403, what we're calling the co-responder bill. And this would essentially set up a structure that would allow mental health and substance use professionals to co-respond with law enforcement to 911 calls that are mental health or substance use related. So when the 911 operator either hears from the caller or gets signals that kind of prompt them to think, oh, this might be a mental health or substance use call, what they'll do is deploy mental health and substance use professional alongside law enforcement. So this bill really kind of sets up a structure to help make that happen. And this bill also layers on top of the Georgia Mental Health Parity Act really well. So they work together, they complement each other. And so we're very pleased to see that moving forward as well. And I think we'll see that bill get across the finish line. So I'm happy to cover any of the other bills if you all are just, raring to hear about one of these other bills. But for the sake of time, I will say that in addition to what's already happening now, we of course always have to think forward about what's coming next. And on the mental health and substance use horizon, hopefully, if there's successful passage of the Georgia Mental Health Parity Act, we'll see that implemented. Really, when legislation is implemented, that's kind of, or excuse me, when legislation is first passed and then signed into law, that's kind of phase like, that's like half the battle. So after it's passed, then all the like public agency and mechanisms have to kind of like get going, and then the implementation has to happen. And often once a new law is in place, we kind of forget about it and then move on and go to the next thing. But the implementation of these laws is incredibly important, because if they're not implemented well, then we're left with the same problem that we were trying to fix in the first place. Also on the horizon, I think we will see in 2023 the conversation come back to coordinated care for high need youth. This was built into the original Georgia Mental Health Parity Act. There was some consternation about how to balance the privacy concerns for young people who are high users of crisis mental health and substance use services versus the need to be able to coordinate their care and share information about them in order to coordinate that care. The legislature has not quite found the right balance between those two things yet. So I think we'll come back to this issue with a little more time and study. I also think we'll see the legislature come back to supported housing, which is really kind of housing that is paired in the same location with support services that help people with mental health or substance use issues get to recovery and then maintain that recovery. So those support services could be on-site therapy, it could be any number of things that kind of help folks maintain whatever their version of recovery is from mental health and substance use conditions. So I'm going to switch gears here. I'm going to move from mental health to health coverage and affordability. And really when I use that term, I'm really thinking mostly about kind of private insurance coverage in the state. And so, what does that look like, and how is that changing in the right now in the legislature? So this time I'm going to start with the budget. So in the coming year's budget, and when you see the term state fiscal year 23, that budget will start July 1 of this year. So it's the budget that's about to start. So there's $124 million in that budget to help lower premiums on the ACA marketplace through what's called a reinsurance program. And I won't dig into the details about how that works, but this program is incredibly important because it particularly targets regions where premiums are highest. So rural Georgia, where premiums are highest, they get more help to lower premiums than Metro Atlanta, where we have the lowest premiums in the state. So it's a kind of a tiered system that really kind of helps bring premiums into alignment across the state. So we're really pleased about that reinsurance program. There's also $15 million in here to fund the governor's effort to separate Georgia from healthcare.gov with no meaningful replacement. So this is a process that's been kind of, in process for the last 2 years. And we are very concerned about it. The Biden administration has intervened, and we do expect to hear whether or not this plan will be able to proceed in sometime probably before the end of the summer this year. But for now, the budget does include $15 million to potentially separate Georgians from healthcare.gov. And then the budget also includes $800,000 to implement what's called an all-payer claims database. And this is a really important tool for policymakers to understand healthcare costs. So what does a knee replacement cost at St. Joseph's versus what does a knee replacement cost at Phoebe Putney? They can also understand outcomes. So are there a lot of reinfections or, when you at the Gainesville Hospital versus at Grady Memorial here in Atlanta? And they can understand kind of some drivers around those costs and outcomes, as well as disparities. So these databases can be really powerful. Some states have used them incredibly effectively, but we have to build this database in a way that makes it effective and useful, and Georgia's just kind of at the beginning of that, but we are hopeful, and we are advocating that it be an incredibly useful tool for our policymakers as well as the rest of us. There are a number of bills here that also kind of touch on private coverage and affordability. One of those is updating our surprise billing law to explicitly include mental health and substance use emergencies. So this means that if you have a mental health or substance use emergency and you go to the closest emergency room for care, even if that emergency room is not in your insurance network, you cannot get an out-of-network bill for it. You can only be billed what you would normally pay at an in-network facility. So we're really happy to see this bill. It's an excellent addition to the existing surprise billing law. SB 341 would essentially make it easier for people to get what's called prior authorization for prescriptions that they need for an ongoing basis. So not a one-time prescription, but if you always need insulin for diabetes, SB 341 would really help to ease the process that doctors and patients have to go through to kind of get that pre-approval from their insurance companies. So also a positive step forward. And HB 867 is really kind of about lowering drug costs by making sure that that there are some middlemen in the drug supply chain, that those middlemen pass along all of the savings that they accrue to consumers, so that when you purchase a prescription at the pharmacy counter, that you're getting all of the savings that are possible at that point. And we so that should kind of help cushion the pocketbook a little bit. And on the horizon in this area, there are a couple of positives and a couple of things we're really really want to get done before they run out. And one of those is at the federal, or two of those are at the federal level. The American Rescue Plan was Congress passed last March, so March 2021. That bill included extra premium discounts for people who buy their coverage through the Affordable Care Act. Those discounts expire in December at the end of this year. Those discounts have been incredibly important for increasing coverage in Georgia. Our marketplace coverage, our ACA enrollment went up from around 500,000 people to 700,000 people this year, largely because of those premium discounts. So we really, really want those discounts to continue. So Congress will need to reauthorize those. There is also a possibility that Congress could essentially temporarily fix Georgia's coverage gap. So we have not expanded Medicaid, which means low-income Georgians, low-income adults do not have a pathway to coverage in our state. They can't get health insurance in any affordable or reasonable way. And Congress has the opportunity to put in place a multi-year fix for that. So we would really like to see that happen in addition, kind of in the same package with getting these premium discounts reauthorized. And at the state level, of course, as I mentioned, we really want the all-payer claims database implementation to continue moving forward in a really robust manner. So we'll be advocating for that. And of course, we are kind of watching the potential separation from healthcare.gov, and we are preparing, if Georgia separates from the marketplace, we're preparing so that to help consumers understand what they need to know in that situation, and how to navigate health insurance shopping and enrollment. And we're also, we've spent much of the last few years advocating that this doesn't happen. So we have our fingers crossed and we're waiting to see. And I will, before I hand things over to Leah, I'll just remind you to please read this Georgia Mental Health Parity fact sheet that I'm about to put in the chat, and call Senator Ben Watson to show your support for the bill. It's incredibly important. So thank you very much. And I look forward to the conversation after Leah presents.
Thank you, Laura. That was very informative. And Leah, I want to introduce you because you're such an important part of this puzzle that we're talking about this evening. Leah Chan is an MPH. She's a senior policy analyst at the Georgia Budget and Policy Institute, where she focuses on state policies that give Georgians a fair and just opportunity to be as healthy as possible. Prior to joining GPPI, I can't ever say it, in 2022, Leah worked for over a decade at the Centers for Disease Control and Prevention in strategic partnership, policy, and communication roles, and focused on a range of public health priorities from suicide to autism. She holds a BA in Spanish from the University of Georgia and an MPH from Emory University. And welcome, Leah, to our conversation tonight. Thank you.
Great. Thank you, Lizanne. And thank you so much to Rosemary for organizing this great event. All right. And does that look right? Is that in, do y'all see it in presentation mode?
Yes.
Here? All right, perfect. Wonderful. Okay. I love it when technology works. So yes, thank you again for having me here and for the opportunity to chat with you all. So as was mentioned, I come from the Georgia Budget and Policy Institute, which is a nonpartisan organization really focused on research and state budget analysis, intended to support solutions that expand economic opportunity and well-being for all Georgians. So I'm really going to continue in the same vein as Laura and sort of focus on the legislative state of play, but particularly for two of my favorite topics, so for public health and Medicaid. So I'll talk first about public health, which has gotten a lot of attention in the past couple of years. So I'm sure you all already know that public health is really intended to save lives and protect people from health threats. And Georgia has a state Department of Public Health, which funds and collaborates with Georgia's 159 county health departments and 18 public health districts, including the Coastal Health District, which is located in Savannah. So legislatively, there are a couple of areas in public health that have been getting some attention this year. So the first is public health infrastructure. So even prior to the pandemic, public health workforce here in Georgia was really paid below market rates. And with the addition of the stress and the turmoil of the pandemic, the department has seen a lot of turnover and issues with recruitment and retention. And this really impacts the strength and sustainability of our public health system here in Georgia. So in response to that, the budget for the next fiscal year includes $40 million to provide cost of living increases for full-time employees. It also includes, in addition to that, $16 million increase for salary increases for select job categories in the Department of Public Health. So what do we mean by public health worker? So that could be a lab worker at the public health laboratory in Waycross doing newborn blood screening to make sure babies born in Georgia with certain genetic and metabolic disorders are identified early. It could be a nurse in Glenn County who's doing home visiting with low-income first-time parents to really support healthy child development. Or it could be an epidemiologist at the Coastal Health District office in Savannah who's collecting and analyzing data to help us understand who's dying of drug overdoses and how many people have died by suicide in the past year. So these public health workers are really doing critical work, and these COLA increases and salary increases are important for retaining well-qualified folks. So public health, covers a whole lot of topics, but two in particular that are getting attention this year and that I thought you all might be interested in are maternal mortality and childhood lead poisoning. So you heard a little bit about sort of the really alarming rates of women dying by pregnancy-related causes and pregnancy-associated causes here in Georgia, particularly Black women and women in rural communities. But to really drive that home, so for every 100,000 births, there are 25 deaths due to pregnancy-related causes, which include heart disease and stroke, infection, or severe bleeding. And then on top of that, for every 100,000 births, there are over 69 pregnancy-associated deaths, like deaths due to drug overdose or homicide. But the good news is that 87% of these pregnancy-related deaths in Georgia are actually preventable. So a couple years ago, there was a study committee in the House on maternal mortality, and some of the recommendations that came out of that study committee are reflected in this year's bills. So there's a bill that would allow pregnant women who have committed a crime to delay their sentence until 6 weeks postpartum so that they can complete their pregnancy and give birth outside of prison or jail. There's also a bill that would charge medical examiners with conducting death investigations on women who died during pregnancy or in the first year after childbirth. And this information is so important for helping us better understand why are so many women in Georgia dying during and after pregnancy, and how can we prevent these deaths? And there's also more than $1.4 million for a variety of different sort of pilot programs to really address maternal mortality, including a pilot program to address specific issues among pregnant women in rural populations, as well as a care management pilot for high-risk pregnancies. Another issue that has actually been studied by the Georgia General Assembly in the past couple years is childhood lead poisoning. So I'm sure you all know that even low levels of lead in the blood have been shown to negatively affect a child's intelligence, their ability to pay attention, and academic achievement. So it's really important to catch it early to prevent further exposure and to reduce the damage to a child's health. So as a first step to sort of tackling the recommendations from the study committee on childhood lead poisoning, there is a bill that would align Georgia's standard for lead poisoning with the national standard, which ultimately means that there will be more opportunities to intervene among children who have elevated blood levels. And then there's also an addition in the budget to reflect to reflect that legislation that would add additional inspectors and testing machines needed to begin testing the homes and the daycares and the other areas where these children who test high in their blood levels might be present. So as this legislative session sort of winds down, it's important for us to look to the future and talk about, what might be on the horizon. So as I mentioned, one really important issue is public health infrastructure and public health preparedness. So as we emerge from this pandemic, how are we incorporating the lessons learned? How can we strengthen our delivery of essential public health services now, and also make sure that we're prepared for future natural disasters or future pandemics? So unfortunately, according to the some recently released rankings from Trust for America's Health, Georgia actually fell from high to medium tier in terms of public health preparedness. So we definitely have room for improvement there. So a couple of opportunities around, sort of public health infrastructure. So although the public health budget increased somewhat due to an influx in federal funding during the pandemic, our total state and federal funding for public health has remained relatively flat in Georgia. So one area of opportunity might be to restore public health funding to pre-recession levels. So when you look at it as an overall sort of pie chart, 6% of the state's health-related spending is dedicated to public health. So that's a pretty small amount. But public health investments can really deliver strong returns. So we talked about childhood lead poisoning. These lead abatement programs can save up to $200 for every $1 invested. So really, in order to improve the health of Georgians and really contain our state healthcare costs, in the long run, it's important that our state invest in preventing people from getting sick and injured in the first place. So another lesson learned from the pandemic is the need for real-time actionable data. So modern, adaptable, secure data systems are really important to detect new health threats, to help us better understand what populations are increased risk for illness and respond quickly with the appropriate interventions. And then thirdly, we talked about this a little bit already, none of this would be possible without a qualified, robust workforce. So we've really been hit by staffing shortages that hampers the public health system's ability to serve the public. So recruiting and retaining a diverse workforce could look like the salary increases as reflected in this year's budget. It could also look like things like expanding Medicaid reimbursement for community health workers, which could also help ensure that Georgia's public health workforce reflects the growing diversity of Georgia's communities. So another hot topic in public health and sort of lesson learned from the pandemic is the importance of building resilient communities by investing in health equity and the social determinants of health. So the pandemic really laid bare the ways in which structural inequities impact the health of Georgians. So the impact of this inequity affects where someone lives, they learn, they play, they worship, and creates disparities in access to a range of social and economic benefits like access to affordable nutritious food options, access to stable housing, and financial security. And these conditions are often referred to as the social determinants of health and are really the key drivers of health disparities that put Black, Latino, and rural populations in Georgia at greater risk for these poor health outcomes. So traditionally, budget-wise, we placed a lot of attention on medical care, but it's really these social determinants of health that account for up to 80% of health outcomes. So it's important for us to prioritize policies and budgetary solutions that allow Georgians to better understand and respond to these health disparities, like maternal mortality, which I mentioned impacts Black mothers and mothers in rural communities at a much higher rate. And it's often said that those closest to the problem are also closest to the solution. So it's so important that we center the voices of those most disproportionately impacted and fund community-driven solutions. And thirdly, to get at the root causes of many of our most urgent health crises, as I mentioned, it's really important to begin looking towards this social determinants of health framework. So I'll give an example to make it a little bit more concrete. So in North Carolina, they have developed a pilot program that will leverage over $650 million in Medicaid dollars over the next 5 years to address housing, food insecurity, transportation insecurity, and intimate partner violence. So it's really important for us to track the success of programs like these and determine if they could be replicated here in Georgia. All right, so I'd like to move on and talk about a little bit about the legislative outlook as it relates to Medicaid. So there's been a couple of really exciting developments this year around ensuring that Georgians have access to the healthcare coverage that they need. So the first bill is one that would extend Medicaid coverage up to 1 year postpartum. So this really builds upon an existing law that was passed in 2020. So in 2020, Governor Kemp signed into law House Bill 1114, which authorized the Georgia Department of Community Health to apply for a waiver from CMS to expand postpartum Medicaid coverage from just 60 days to up to 6 months after birth. So in 2021, that waiver was approved, and it specifically allows for women who make less than 225% of the federal poverty line, which is about $30,557 per year, whose incomes would actually be too high to qualify for Medicaid as parents, and thus they would normally lose coverage after 60 days postpartum. This allows them to continue their coverage. And this new bill would actually allow new parents to extend it out from just 6 months to a year. And this is really important because more than 1/3 of pregnancy-associated deaths, which we talked about already, are preventable, many of which are preventable. They occur during that time between 6 months and 1 year postpartum. So it's really vital that we extend that postpartum coverage. And as you can see, the budget actually already accounts for enactment of this bill. So that's really exciting as well. So another development is the movement of a bill that would direct the Department of Community Health to apply for an 1115 waiver to expand Medicaid to uninsured individuals living with HIV. So some of you may know that the number of people living with HIV in Georgia has increased over time. And in fact, the latest CDC data show that Georgia actually has the highest rate of new HIV diagnoses across the nation. So we already have a federally funded program that has also state funding as well, called the Ryan White HIV/AIDS program. But unfortunately, the number of folks that are in need of testing and treatment services has outpaced the capacity of this program. So by expanding Medicaid to folks living with HIV who are uninsured, it would allow folks who are enrolled in that program to move to Medicaid, and would ultimately save the state millions of dollars and allow these folks who are eligible for Medicaid living with HIV to actually access not only the testing and treatment and all that's provided by Ryan White, but all of the wraparound services that can really keep someone well. And I'm sure, as you know, when it comes to HIV, treatment is prevention. So providing individuals with HIV the care and treatment they need can lead to suppressed viral load and actually decrease transmission. So all of this could really help save lives and save Georgia money. So looking to the future, so as you all may know, in March 2020, CMS temporarily waived certain Medicaid and CHIP requirements and conditions. And the idea was they wanted to prevent people with Medicaid and CHIP in all 50 states from losing their healthcare coverage during the pandemic. So like, what are we like now? 2 years later, states will soon be required to restart these Medicaid and CHIP eligibility reviews. And when these reviews resume, it could mean up to 15 million people across the United States could lose their current Medicaid or CHIP coverage through a process called unwinding. So the states have up to a year to do those eligibility assessments, but the extra federal money that we've been getting to cover those additional people on Medicaid isn't going to last for more than 3 months after the public health emergency declaration ends. So that means Georgia will be having to cover a bigger portion of the costs associated with this larger Medicaid caseload that we've had while we finish this sort of quote unquote unwinding. So it's been estimated that 11% of Medicaid enrollees in Georgia will be determined ineligible, which would amount to more than 200,000 people, including children. And people may be cut off for reasons that have nothing to do with their eligibility. In the renewal process, it could be that there's an outdated address or some sort of computer glitch that inadvertently sort of kicks people off. And as I mentioned, this also includes children. So an analysis from Georgetown found that Georgia is one of 5 states most at risk for children losing coverage due to this sort of like churn issue. So anyway, all that to say, it's a very important issue to keep our eye on as we look to the future. So I'm gonna, for the sake of time, skip these next 2 and talk about this one, which I'm sure you all know a lot about, but is super, super important. And this graphic is awesome and made by our friends, Laura and friends at Georgians for a Healthy Future. So the Affordable Care Act Medicaid expansion expanded Medicaid coverage to nearly all adults with incomes up to 138% of the federal poverty level, and provided states with enhanced federal matching rate for their expansion populations. So to date, there are 39 states that have adopted Medicaid expansion and 12 states, including Georgia, that have not. But if Georgia were to fully expand the Medicaid program as allowed under the ACA, there would be between 500,000 and 600,000 Georgians that would be eligible to obtain health insurance. And I'm sure, as you can see on this slide, and as you have probably read in the news, so in December 2021, CMS withdrew Georgia's Section 1115 approval for the work and premium requirements under Governor Kemp's Pathway to Coverage plan. However, in January 2022, Georgia then filed a lawsuit challenging CMS's withdrawal. So the waiver was initially approved in October 2020, and it gave Georgia the authority to extend Medicaid coverage for certain parents and childless adults. But it would have been conditioned on the now withdrawn work and premium requirements. So the state is not currently implementing the coverage provisions while it's sort of pursuing this litigation. So as you can see on this slide, there's sort of 2 options for moving forward with additional coverage to get more Georgians covered, but fully expanding Medicaid under the ACA would not just get more Georgians covered, but it would also be at less cost. So that's something to look to for the future. I mean, obviously it's been a topic for many, many years, but it is obviously a very hot topic in the gubernatorial race and will be a hot topic, I think, in the legislature for years to come until there is some sort of resolution. So lastly, just wanted to speak to a couple of really simple calls to action. So the first one is to email, call, write your federal delegation, so your representative and our 2 state senators. So as you all may know, there was about $15 billion meant to cover COVID-19 testing, treatment, and vaccination that was intended to be included in the federal appropriations law that was signed several weeks ago, but it was not. And so that is already impacting Georgia's uninsured population. So as of this week, HRSA is no longer going to be providing reimbursement for providers that are providing testing and treatment to Georgia's uninsured population. And a couple of weeks from now, it will be the same for vaccination. And there's many other sort of impacts that this will have. It also impacts, folks who are over 65. It impacts the ability to, or for the 4th booster, it could impact the government's ability to buy the 4th booster for folks that may need it. So anyway, this has wide-reaching impacts, but most importantly, it has immediate impacts on Georgia's uninsured population. So it's really important that those federal programs continue because it really has an impact on our state. And then the second is just to call, email, or write your state representative or senator and talk to them about whatever public health or Medicaid issue you heard today that you feel most passionately about. And you can always visit our website, gbpi.org, to read the latest legislative issues. We have bill analyses, we have analysis of the budget, so lots of good research and data there. And with that, I will end. Thank you so much.
Thank you, Leah. We appreciate all the panelists. We're going to move on to questions. Our first question is for Laura. Laura, the question is, what's the status of the Medicaid waivers that Governor Kemp signed and forwarded to DHS for implementation?
Yeah, so those are, Leah spoke to one and I spoke to the other. So the first one, and I put a link to a little blog about the first one, which touches on private insurance. So the private insurance waiver is called Georgia Access. It is still officially approved, so it can move forward, and that's the one that would separate Georgia from healthcare.gov. People could still enroll in plans and be eligible for financial assistance, but the shopping and the enrollment would get much harder, and we anticipate many folks would lose their coverage as a result. So that plan is still technically in place. The state is moving forward with implementation. It is supposed to be implemented as early as this November. The Biden administration did request new information from the state about how that plan would impact people, especially given COVID-19. It was approved, that plan was approved before COVID-19 existed. So we may see a change in opinion from the federal government on that plan. And if we see that, it would likely be this summer. So that one's on track to be implemented, although there may be a roadblock. The other waiver, we don't tend to use the words waiver in public because they're complicated and confusing, but the other one is this plan that Leah spoke to called the Georgia Pathways Plan. And what that would do is, as Leah alluded to, kind of extend coverage to people below the poverty line who don't already qualify for Medicaid or another health insurance pathway, but it does not go as far as Medicaid expansion. So it would cover 270,000 people at a greater cost than a Medicaid expansion, which would cover about 500,000 folks at about $215 million a year, which is about a third of the cost of the Pathways program. The state can implement the Pathways program at any point that they'd like. It's an approved program. They have all the thumbs up they need from the federal government. The governor at this point is choosing not to cover people with his own plan, and they're choosing not to cover people through Medicaid expansion. So two active choices to cover zero low-income people.
Thank you. And the next question I think would be for Laura and for Leah. And that's, could you possibly in the chat give us the bill numbers so we can pass them along to the members so they can call their legislators. So if you could put that information in the chat feature, that would be helpful to this group. And I think the question was answered from Nina, which is what is the income related to 225% of the federal poverty level? And so I think, Laura, you want to speak to that, or Leah?
Oh yeah, and Leah, I put the poverty levels I put in there are the Medicaid expansion poverty levels. So
Leah,
if you want to speak to the other ones.
Oh, I'm sorry. Okay, let me go back in the chat.
What's the income related to 225% of the federal poverty level?
Oh, okay. Yeah, gotta type it into the little calculator. Okay, so for, let's see, for a family of two, that would be about $41,000 and some change.
Okay, thank you. Okay, and then we had a question in the Q&A, and Laura, I know that you've answered this, but folks might not have seen it. Jenny asked, am I confused? What does leaving healthcare.gov really mean? And that we don't have a state that covers the ACA, and how are they doing that? while providing funds for ACA premiums?
Yeah, so this is complicated. So I first want to clarify, I don't want anybody to get super scared. I mean, this plan is not a good plan, but the ACA will still be in place in Georgia. We will still be covered by the protections and receive premium discounts. But essentially, the ACA has a part of the ACA law is it allowed states to essentially experiment with how to best deliver private insurance to their populations. This part of the law was included for states like Colorado or Hawaii or Vermont who might want to experiment with like a single payer system, who might want to go beyond the ACA. Under the Trump administration, they reinterpreted the law and essentially allowed so much flexibility that it opened up the opportunity for states to erode the Affordable Care Act instead of building on it. So essentially what Georgia has done is it saw that open door and has walked through it and said, instead of having a one-stop shop where people can get unbiased information about the plans that they qualify for and the financial assistance that they are eligible for, and get assistance to enroll in those plans, instead of having that nice one-stop shop that's like easy for people to use, we are going to stop people from using it. It's also the most popular way that people enroll in coverage through the Affordable Care Act is through that one-stop shop. So we're going to shut off the most popular pathway into the program, and we're not going to replace it with anything. So people can still get in, they can still enroll in coverage through insurance brokers or insurance companies, but there won't be a place where they can get unbiased information, see the financial assistance they qualify for, only look at comprehensive plans. So insurance companies could say, like, here's this comprehensive plan with a $100 premium, and here's a short-term plan that we're not going to tell you doesn't cover mental health or pregnancy or prescription drugs, but it only costs $25 per month as a premium. And so insurance companies would be allowed to do that, and people who shop would understandably be confused and may reasonably end up underinsured, or get lost in the process altogether, not know how to navigate it, and become uninsured. So that's kind of the world that the Governor Kemp's plan proposes, is that we would go back to a world where we don't kind of have an easy way to navigate health insurance. But the plans would still exist, and so would the assistance. But you'd have to really do the work to find it.
Thank you, Laura. I think that concludes all of our questions. I want to thank our panelists this evening, and I'm going to turn it over to Rosemary.
So first of all, thank you to all of our listeners to our webinar today who signed on. Thank you for joining us. I hope that we succeeded in what we try to do with all of these, which is to provide you with some of the education that we feel is missing when we talk about some of the big issues of our day, whether it's climate change or voting rights or healthcare. We wanted to give you some of the down and dirty about what really is happening with healthcare in Georgia. To our panelists, I'm incredibly grateful. Healthcare, as many of you know, is one of my passions, and I've been fortunate enough to get to know some of you along the way since I moved to Georgia, specifically Laura, who was very helpful in having me think about this and how we should put a panel together. She kept telling me that there was a position at the Georgia Budget and Policy Institute that was vacant, and that she hoped that somebody was going to fill it. And we raised a big cheer when Leah was appointed, and she has not disappointed at all today. Thank you, Leah. Laura knows how much I value her input into everything. We've worked well together. The piece that was missing, because I am an avid reader of the Commonwealth Fund's white papers that come across my desk very regularly, I really wanted somebody from the Commonwealth Fund, but I didn't. Laura and I weren't sure how we could break into that. And, you know, there's serendipity in lots of things. And I was bemoaning this at one of our League of Women Voters board meetings. And one of our board members, our lovely Michaela Shank, said, oh, I have a relative who works for the Commonwealth Fund. Let me work on it. And lo and behold, the next day, we had a link to David. And David, thank you so much. It was so interesting to see how all of this comes together. And finally, Lizanne, we are so pleased that you were able to join us to be our moderator and to do all of the introductions. This has been really a very interesting topic this evening. I hope that we can share our webinar. We will put it on the League of Women Voters website tomorrow. And I hope that we will be able to share it with a lot of other people. We need to think about how we do that, Lizanne, because there are definitely people here in Savannah who we should be sharing this with. This is our last issues meeting of this year, because as you know, election season is upon us, and the League of Women Voters is renowned for forums where it showcases the candidates who are going to be running for office and who you're going to be asked to vote for. And we will be beginning those forums next month. So we will have a little hiatus, and maybe after the holiday season at the end of the year, we'll begin thinking about how we start up with these again next year. But thank you all so much for joining in tonight. This has been wonderful. It certainly exceeded my expectations. Thank you, and good night.